Hi, everybody. My name is Michel Delforge. I'm a clinical hematologist working at University Hospital Leuven in Belgium. So it's my pleasure to discuss the topics of, let's say, advanced immunotherapy with CAR T cells with bispecific antibodies in relapsed refractory multiple myeloma. Now, I think you will all agree with me that patients with relapsed refractory multiple myeloma, that means patients who have exhausted the current therapeutic options like IMiDs, proteasome inhibitors, anti-CD38 monoclonal antibodies, that those patients have a high unmet medical need. And the positive news is that with anti-BCMA CAR Ts, we have seen unprecedented responses. I just want to draw your attention to the published data with ide-cel from the KarMMa study and with cilta-cel from the CARTITUDE-1 study. In both studies, patients had received a median of 6 prior lines of treatment. The majority of these patients were triple-class refractory, and a significant percentage of those patients were penta-refractory. Nevertheless, the majority of patients responded to anti-BCMA CAR T, with a very high percentage of patients achieving complete responses, which was more than 30% with ide-cel, and with cilta-cel, up to 82% of patients achieved a stringent CR. And those deep responses translated into impressive progression-free survival and unprecedented overall survival rates for those patients with unmet medical need. Now, currently, ide-cel is approved by the European Medicine Agency for patients who have received at least 3 prior lines of treatment, including a proteasome inhibitor, an IMiD, an anti-CD38, and whose disease is progressing. And very recently, the FDA also approved cilta-cel. Now, currently, the truth is that the access to anti-BCMA CAR Ts is still very limited in Europe, because in many countries, there is not yet a reimbursement of ide-cel. And for instance, in my country, we still have to rely on clinical studies to give patients access to CAR T or to other forms of advanced immunotherapy like anti-BCMA bispecific antibodies. Regarding other targets, now maybe I'll first discuss now anti-BCMA bispecific antibodies. In addition to CAR T cells, there are also bispecific antibodies that target BCMA, like, for instance, teclistamab, like elranatamab. But there are also other targets next to BCMA for bispecific antibodies, for instance, GPRC5D, which is targeted by the bispecific talquetamab. There is also the Fc receptor homology domain that is targeted by cevostamab. So there is really an expanding number of drugs that are being evaluated in relapsed refractory multiple myeloma. It's clear that we are still at the beginning of a completely new era. First of all, despite the excellent results with anti-BCMA CAR Ts, many patients will ultimately relapse. So there are efforts being done in improving the efficacy of CAR T cells by, for instance, looking at other targets, but also CAR Ts that target 2 different antigens. Also, the fitness of the T cells is very important. So in other words, to collect the cells earlier and not after the patients have been exposed to many different anti-myeloma drugs, and by earlier collecting the T cells to try to increase also the quality of the CAR T cells, looking at specific subtypes of T cells like, for instance, memory T cells. Also, there is this manufacturing time of autologous CAR T cells that can take up to 8 weeks. So also the concept of off-the-shelf allogeneic CAR T cells is being explored. CAR T infusion can be associated with toxicities like cytokine release syndrome. So also NK cells are being explored as potential immune effector cells. So you see there's really rapidly expanding research, and we are still at the beginning of a long journey where finally we will be able to use immune effector cells for more myeloma patients. We will be able to use them strategically better in order to increase their efficacy. On the other hand, there is the era of the bispecific antibodies. And what we currently know is that bispecific antibodies targeting BCMA or other antigens are also highly effective in relapsed refractory multiple myeloma. They have the big advantage of being off-the-shelf products. They can be associated with CRS, but CRS is usually mild to moderate. And that is partially related to the fact that these drugs can be given in a step-up dosing to reduce the risk for severe CRS. But we have to wait for longer follow-up to see what will be the median progression-free survival and also the overall survival of bispecific antibodies compared to CAR-Ts in a similar setting. And finally, in conclusion, we believe that those new developments will, without any doubt, create new perspectives for many myeloma patients. And because of these drugs, we are confident that we'll be able to control the disease better and for a longer time in many patients. And we can even start dreaming of being able to cure more patients with the introduction of these new agents.